I am Prashant Agrawal. I'm head of marketing. On the behalf of Adley Oncology, I would like to welcome our eminent guest speaker, Dr. Aditya Jandial and Dr. Ashish Bazil. Along with this, I would like to welcome our respected participants and the discussants. It is our privilege to have the eminent personality, Dr. M.B. Agrawal sir, uh, in this webinar. With your permission, sir, I would like to present few slides about the Adley Oncology. Adley Oncology has a mission about the advanced healthcare through innovation, quality, and the collaboration. Recently, Adley Oncology has got the certificate as a top manufacturer of India by the Pharma Outlook. Adley Oncology is one of the top manufacturer of the widest range of anti-cancer drugs in India, not only in the formulations, but it has the APIs always as well. API means the raw material. Adley Oncology not only focusing on the formulations, but also it is focusing on the research and development. That's why today we are having the one of the biggest portfolio of 135 plus SKUs. We have recently launched Adexet OS, which is addressing unmet need in pediatric patients, which is bioequivalent to the tablet. That is methotrexate oral solution. Not only this, our guiding principle is the patient first through patient compliance, patient support, patient education, and the cost effectiveness. With this, I just want to thank all of you, and I would like to hand over the session to Dr. M.B. Agrawal, sir.
Thank you so much. Good evening to one and all. Today, we have got two guest speakers, Dr. Aditya Jandial from Chandigarh and Dr. Ashish Bajel from Melbourne. This webinar is brought to you by Mumbai Hematology Group. It is supported by Adley and Johnson & Johnson, managed by Perfect Square. I'm grateful to Team Adley and Team J&J, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Aditya Jandial and Dr. Ashish Bajel. All our discussants were themselves eminent clinical hematologists or medical oncologists, and you participants for sparing your Thursday evening. Coming Thursday, that is 6th of August, we have three activities. The first is a lecture by Dr. Neeraj Arora. You all know him from the Unipath Lab, Ahmedabad. This will be at 6:30 p.m. and he's going to tell us what he has got in the store about JAK2 negative erythrocytosis. Following this, we have discussion on this new kid on the block, zanubrutinib, which has been a real practice-changing molecule in the field of chronic B-cell lymphoproliferative disorders, specifically CLL. We have a lecture by Dr. Nitin Sood from Gurugram at 7:30. And then we have a panel discussion which will be moderated by me from 8:30. A word about our guest speaker, Dr. Aditya Jandial. He is MD, DM Clinical Hematology from PGI Chandigarh. At present, he is Associate Professor, Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. And he's going to speak to us on a very, very fascinating subject, which has become an absolutely hot cake, bispecific antibodies in relapsed multiple myeloma, the current landscape and future direction. I'm very keen to listen to what is happening in this field from this wonderful speaker. So thank you so much, and over to Dr. Aditya.
Good evening, everyone. Am I audible and are my slides visible?
Yes, Aditya.
So, good evening, everyone. First of all, I would like to thank MB Agarwal sir and Mumbai Hematology Group for giving me this wonderful opportunity to be part of this session today. And in next 45 minutes, it is my privilege to discuss bispecific antibodies in relapsed multiple myeloma, how these drugs have transformed the way we are treating relapsed multiple myeloma in current era and their future implications. So this will be the outline of my talk. So I'll be discussing the rationale for bispecifics in myeloma, the efficacy and safety data from the pivotal trials, prevention and management of toxicity with bispecifics, a little bit about the Indian perspective and the future of bispecifics. So to put things into perspective, so myeloma treatment paradigm begins with the diagnosis and risk stratification, and the patients who are transplant eligible receive induction followed by consolidation and maintenance. And the patients who are transplant ineligible, they are treated with induction followed by continuous therapy. So the goal of therapy is achieve maximum tumor bulk reduction with the induction and consolidation, and maintenance is given to achieve the maintain the disease control. However, one of the fundamental challenges in the management of multiple myeloma is that most of the patients do relapse after variable time periods. And if we look at progressive periods or time periods of remission with subsequent therapies, so there is a progressive shortening of remission duration, which is approximately 18 months with the first line therapy, and it gets shortened to less than 6 months with the subsequent lines of therapy. The second most critical point is the treatment attrition. So we see that with each subsequent line of therapy, about 15 to 35% of patients are lost to follow-up, either because of the disease or the treatment-related toxicity. So a significant proportion of patients are not able to achieve the later lines of therapy. So it is important to bring the effective novel immunotherapies to the earlier lines of therapy so that these patients may benefit from uh, the efficacy of these novel agents. If we look at the treatment options and the pivotal trials, which looked at the specifically early relapse disease. So till recently, we were mainly focusing on daratumumab-based triplets, and we have seen that daratumumab and often combining it with the pomalidomide or carfilzomib, it provides better results as compared to doublets. But we have also seen that the benefits with these triplet combinations are finite. And after a few months, most of these patients do progress on therapy. And these are, if we look at these Kaplan-Meier curves, so we hardly see any flattening. So we need to do more for these patients, and giving them just mere and some additional proteasome inhibitor and immunomodulatory drug is something that we now know that it is not enough to keep these patients under the disease under control for longer duration. And if we look at the real world outcomes of the patients who are triple class exposed, these outcomes in the real world are even more dismal. So overall response rates are close to around 30%, and the median progression-free survival is close to 5 months. And most of these patients, once they have been exposed to the three classes, the CD38 monoclonal antibodies, proteasome inhibitors, and IMiDs, the overall survival is usually less than a year. So what we have seen in last couple of decades is the transformative impact of immunotherapy in multiple myeloma. And if we look at the single agent anti-myeloma activity of various drugs which are available, so these were modest with the proteasome inhibitors and IMiDs. They improved with the monoclonal antibodies, and what we now see is that the CAR T cell therapy, the overall responses with these drugs, they almost reach 100%. And with the availability of bispecific antibodies, the response rates are around 60 to 70% with the off-the-shelf advantage. And this is something that has led to a significant shift in the way we look at myeloma treatment now. So we have started seeing the plateauing of the PFS curves. And if we look at the CARTITUDE-1 long-term data, which included BCMA CAR-T therapy, and now we know that about 1/3 of these patients are disease-free at the end of 5 years. And similar results are there with the teclistamab. And because of these fantastic results, now these have like reopened the discussion regarding the possibility of functional cure with these agents, with the caveat that these immunotherapy options are they come with a lot of toxicity, mainly in the form of infections. If we talk about T cell redirecting therapies in multiple myeloma, so we have CAR T cell therapy and bispecific antibodies. And the first bispecific antibody in multiple myeloma was approved in 2022, which was teclistamab. And in last 4 years, now we have 4 approved bispecific antibody bodies for relapsed multiple myeloma. So these are off-the-shelf immunotherapy options with multiple binding domains. So the target different tumor antigens like BCMA, GPRC5D, and FCRH5. If we look at the mechanism of action, so teclistamab, which is the first bispecific antibody which was approved for treatment of relapsed refractory multiple myeloma. So it binds on one side, it binds to the myeloma cell through BCMA, and on the other side, it binds to the cytotoxic T cells through CD3, and it leads to formation of a immunological synapse. And this ultimately leads to T cell activation. Ultimately, there is cytokine release in the form of interferon gamma, tumor necrosis factor alpha, and ultimately there is the destruction of the myeloma cells through the secretion of perforins and granzymes. Apart from BCMA, there are other bispecific targets in the form of GPRC5D and FCHR5. So these targets they are not only different in terms of their tumor-associated antigen, which they are targeting, but they have other structural differences as well. So what determines the synapse quality also determines the quality of the response. So the antigen density, which is the higher target expression, gives more stable synapses, and low density disease responds poorly. And that is one of the reasons that underlies the interest in the avidity enhanced 2+1 designs. So by 2+1, it means that the bispecific antibody binds to 2 tumor antigens simultaneously and 1 CD3 molecule on the cytotoxic T cells. The effector to target ratio, which is another factor that determines the quality of the synapse. So high tumor burden dilutes the available T cells. Bulky and extramedullary disease responds less well to the monotherapy. The third crucial impact factor is the T cell fitness. So many of these patients have received prior heavy and T cell redirecting therapy, and T cell exhaustion phenotypes, they also predict poor outcomes. The CD3 affinity is one of the important factors for the cytokine release, and the newer constructs are deliberately being designed to lower the CD3 affinity so that CRS intensity is lesser. The epitope and the geometry of the tumor antigen is also something that is significant, because now we have data that 2 different bispecifics, they bind to the same tumor antigens, but they have different responses. And last but not the least is the microenvironment. So we all know that the T regulatory cells, myeloid-derived suppressor cells, and inhibitory cytokines, they blunt the lysis. And this is the rationale for combining bispecifics with other molecules in the form of anti-CD38 molecule antibodies. Coming to the BCMA, it is a therapeutic target and it is a hallmark of plasma cells. It is important specifically to the myelomatous plasma cells, as it plays a key role in the B cell maturation and differentiation. Right now, we have 3 different therapeutic platforms that target BCMA. So there are two off-the-shelf products in the form of bispecific antibodies and antibody drug conjugate like belantamab. And of course, we have cellular therapy, which requires infrastructure and um, uh, specific manufacturing conditions. So let's go through the pivotal trials that led to the approval of these bispecific antibodies in the late relapse. So the first bispecific antibody that was approved was teclistamab in relapsed refractory multiple myeloma. And the trial that led to its approval was MajesTEC-1. It was an open label phase 1-2 trial that included patients who were triple class exposed with no prior BCMA therapy, and the primary endpoint was overall response rate, and the key and secondary endpoints were duration of response, PFS, and OS. The study was published in NEJM in 2022, and what it showed was the impressive overall response rate of 63% in patients who had median 5 prior lines of therapy. The median progression-free survival was close to 11 months, and median overall survival was 18 months. The major adverse events were infections. So they were seen in around 80% of the patients. About half of these patients had grade 3, grade 4 infections. This study was done during the COVID pandemic, and most of the infections were attributable to COVID-19 related respiratory involvement. Nevertheless, the infection-related mortality was close to 12%. And if we look at the median time to infection, it was 1.7 months, and that was almost parallel to the median time to hypogammaglobulinemia, which was 1.2 months. The another aspect of the toxicity was the T cell activation related adverse events. So the cytokine release syndrome was seen in around 72% of the patients, and that was primarily because of activated T cells and pro-inflammatory cytokines. The second, the ICANS, which now we see both of these side effects, the CRS and ICANS with the CAR T cell therapy as well. But the proportion of patients developing grade 3 or grade 4 CRS and ICANS is lower. This is what we saw in MajesTEC-1 trial. And for for teclistamab, we follow a step-up dosing schedule for the very purpose is to mitigate and prevent the cytokine release syndrome. It is given as step-up doses on day 1, 4, and the main dose is given on day 7 or 8. And most of the CRS incidents are usually seen with the step-up doses 1 and 2, and the overall incidence of CRS is 72%. The second BCMA specific BCMA targeting bispecific antibody is eldentamab. So it has a biased affinity for BCMA more than CD3, which favors myeloma cells over T cells. And that makes it less likely to activate T cells in the absence of myeloma cells and decreasing the likelihood of T cell exhaustion. It has full-length IgG2 scaffolding, which maintains the structure of the natural antibody and allows for extended half-life. And it is optimized, these changes are optimized to reduce the immunogenicity. So eldentamab was approved through MagnetisM-3 trial, which was an open-label phase 2 study that included patients with 1 or more prior lines of therapy, and the patients received step-up doses 12 milligram and 32 milligram on day 1 and day 4. And subsequently, they were treated with weekly doses of 76 milligrams subcutaneous till cycle 6. And beyond that, the doses were given in once in every 2 weeks. So if we look at the overall incidence of CRS, so it was around 56%. Most of the CRS incidents happened with step-up doses, with very low incidence in the subsequent full doses. And if we look at the median progression-free survival, so it was close to 17 months with the eldentamab, and median OS was 24 months. The overall response rate was 61% with this bispecific. The third BCMA targeting bispecific is linvoseltamab, and it was approved on the basis of results from Linker MM1 trial. So this was again a phase 1, phase 2 study that included patients with more than three or more prior lines of therapy. What makes this molecule different from teclistamab and eldentamab is first of all, it is an IV bispecific, and the step-up doses are again they are weight independent, 5 milligram and 25 milligram. And instead of day 1 and day 4, the step-up doses are given on day 1 and day 8. So there is like lesser requirement for in-hospital admission. The overall incidence of CRS was 46% with linvoseltamab, and the overall response rate was close to 71%. And uh, the responses were quite amazing with within the quadruplet refractory and penta refractory patients. The fourth the fourth bispecific is talquetamab, that is approved by the FDA. It binds to a novel target, which is GPRC5D. It is a G protein coupled receptor predominantly expressed in plasma cells, including malignant plasma cells. And it is the only GPRC5D targeted therapy approved for the management of multiple myeloma till now. And the results from Monumental 1 trial led to its approval. And it was this trial was a phase 1-2 study, and the talquetamab was studied in the form of two different dosing schedules. So one was 0.4 milligram per kg subcutaneous every week, and the second was talquetamab 0.8 milligram every 2 weeks. So if we look at the overall response rate, so with it was like quite close with the weekly and bi-weekly dosing. Almost 75% of the patient achieved the response. And after a median follow-up of around 38 months, the median PFS was 7.5 and 11 months with this molecule. What is more peculiar with the safety profile of talquetamab is that because it is GPRC5D directed, and GPRC5D, apart from the hematopoietic cells, it is expressed on skin, nails, and the filiform papillae of the tongue. So one of the peculiar toxicities are dysgeusia, skin-related and nail-related changes, and dry mouth. And on the right, you can see the change in the body weight from the baseline once the talquetamab is started. So it reaches nadir within a few months, and subsequently there is gradual recovery. So it requires a more proactive approach as far as the nutritional rehabilitation is concerned. If we look at the overall incidence of infections, so it is slightly lesser as compared to the BCMA-directed therapy. Second aspect of the toxicity is the neurotoxicity. So it is only bispecific that has a very peculiar neurotoxicity in the form of ataxia and balance disorders. And within the Monumental 1 trial, 4.1% of the patients had imbalance, incoordination, and difficulty in walking. So we have seen similar movement disorders and neurotoxicity in the setting of cilta-cel. And we should not forget, we should not ignore these symptoms once they happen in the setting of talquetamab. So this is the summary of the BCMA-directed T-cell engagers. So the overall response rates between teclistamab and elranatamab, they are comparable, around 60%. The linvoseltamab seems to be better in terms of overall response rate, and median PFS with this molecule is not yet reached. But we should be very careful when we are interpreting the cross-trial comparisons, because the patient populations which were included in these trials were different, the follow-ups were different, and it is the cross-trial comparisons, they have their own limitations. This is the summary of the side effects. So the CRS is around 60 to 70%, mostly grade 1 and grade 2. And the infections which are grade 3 or 4, they were higher in BCMA-directed bispecifics as compared to the talquetamab. Can we combine both the BCMA-directed and GPRC5D directed monoclonal antibodies? So Redirect 1 study exactly focused on this question, and it included I would say, very high risk multiple myeloma patients who had true extramedullary disease, and the talquetamab and teclistamab were administered to these patients who had one or more prior lines of therapy in standard step-up doses. And what was seen is that the overall response rate was close to 80% in this very difficult to treat population. And the median and the 12 months duration of response was around 60% with median PFS of 15 months. And after a median follow-up of around 17 months, around 60% of the patients were progression free and the median OS was not reached. So that makes this combination quite lucrative for the extramedullary disease. Cevostamab is the bispecific, which is targeting the FcRH5. And the rationale for this this bispecific antibody is that it is expressed independently from the BCMA and the GPRC5D expression. And in the phase 1, phase 2 data that we have so far, so it is a fixed duration treatment right from the beginning for 12 months, 17 doses. It is given once in 3 weeks. And the overall response rate is close to 90%, which is quite impressive. And the incidence of grade 3 or more infections is lower. And CRS is also lower as compared to the other bispecifics. Now, coming to the early relapse. So because these bispecifics have shown impressive efficacy and manageable toxicity in the later lines. So these have been studied in the early relapse settings with 1 to prior lines of therapy. And this has been the focus of a lot of discussion in last, I would say, 7 to 8 months. So the first was the Majestic 3 trial, which was presented at ASH 2025, and there was a simultaneous publication in NEJM. So this was a phase 3 trial where relapsed refractory multiple myeloma patients with 1 to 3 prior lines of therapy and who were BCMA therapy naive were randomized to receive either teclistamab and DARA or DARA POM-DEX or DARA bortezomib dex. And the primary endpoint was PFS and key secondary endpoints were response rate, MRD negativity, and OS. And the primary endpoint was PFS. So teclistamab and DARA combination was significantly better than DARA POM-DEX, DARA VD, the comparator. And at 3 years, more than 80% of the patients were disease-free and alive. And there was early separation of the Kaplan-Meier curve. If we look at the overall response rate, so it was close to 90% as compared to around 75% with the comparator. And among the patients who responded, the MRD negativity was almost 90%. So that is quite impressive in the early lines of therapy. The OS in the Tec-DARA combination arm was around 83% at the end of 3 years with a hazard ratio of 0.46. And if we look at the overall safety profile, so CRS again was quite common, mostly grade 1. The ICANS was negligible. And if we look at the summary of infection, since this was done during the COVID-19 pandemic again, so a lot of infections because of COVID-19 were there. And the profile of infections was not quite different from Majestic 1, which I have highlighted earlier. There is another trial which is Majestic 9, and this was presented at ASCO this year, and this is something that relates more to the real world. So this included patients who were both lenalidomide and DARA refractory in early lines of therapy, and it was again a phase 3 study where teclistamab was compared with the comparator, which was pomalidomide borti-dex or carfilzomib dex. And if we look at the primary endpoint, which was progression-free survival, so teclistamab monotherapy significantly improved the progression-free survival with a hazard ratio of 0.29, which means that there was 71% reduction in the risk of disease progression or death as compared to the comparator. And there was a significant difference in terms of overall response rate in favor of teclistamab monotherapy in this study population. And the median duration of response, which was not reached in teclistamab, and with the comparator, it was just 13.4 months. And if we look at the overall survival, so at 18 months, the median overall survival, the median was not reached. So almost 80% of the patients were alive as compared to 68% with the comparator. So the third trial which has again incorporated bispecific, and it was the plenary session at EHA 2026, and it compared the talquetamab based combinations and compared them to dara-pom-dex. So there were three arms, and the patients were randomized in a 1:1:1 fashion to receive either talquetamab with dara, talquetamab dara, and pomalidomide, and third was dara pom dex, which was the comparator. And what we have seen is that around more than 80% of the patients with talquetamab dara pom combination were progression free and alive at 2 years, and as compared to around 50% with dara pom dex. So both the combination talquetamab and dara talquetamab and dara pom, they were significantly better in terms of progression free survival. The overall responses were close to 90% with the talquetamab based combination as compared to 77% with dara-pom-dex. And MRD negativity was almost half of these patients had MRD negativity as compared to just 15% with dara-pom-dex. And again, with the talquetamab based combinations, we saw more weight loss, more dysgeusia, nail and skin changes, and dry mouth. So these, so there was no safety signal when the talquetamab was studied in the early relapse setting. And when we discuss about the toxicity, so I think we need to be more vigilant with the way we administer these molecules in the real world. So the first problem is CRS. So the University of Miami actually started using prophylactic tocilizumab first in the patients who were receiving step-up doses, and it was seen that with the use of prophylactic tocilizumab at the dose of 8 milligram per kg, the CRS incidence was brought down to less than 10%, around 8% with the 8 milligram per kg. And now we have data for even the low dose tocilizumab, which is 4 milligram per kg, and we know that the overall the CRS rate with even the low dose tocilizumab, it is 23% as compared to around 60%, and the grade 2 CRS is now brought to 2% with the low dose tocilizumab. So it is not just cost saving. So I think hands down the use of tocilizumab brings down the incidence of CRS. The second aspect of toxicity is the infections. So infections in multiple myeloma, I would say it is multifactorial. So we have patient-related factors because of age, frailty, comorbidities, and poor performance status. The disease biology also adds to the risk of infection through immunoparesis, cytopenias, and renal dysfunction. And on top of that, these patients receive steroids, alkylators, proteasome inhibitors, IMiDs, and CD38 monoclonal antibodies. And that leads to cytopenias, impaired humoral and cellular immunity. And what we ultimately see is that the 7 to 10% increased risk of bacterial and viral infections in these patients. And when these patients are given bispecifics or CAR-T, we should understand that we are not starting with a normal immune system at that point. And when these patients receive these T-cell engaging therapies, so it creates a kind of tipping point. And what we see is the sharp rise in severe infections and often opportunistic infections. And there are fundamental differences between bispecific and CAR-T, how they reshape the immune system. So we know that in bispecifics is a continuous T-cell engagement paradigm, and there is sustained depletion of normal plasma cells and frequently normal B-cell compartments. We see prolonged hypogammaglobulinemia and lymphopenia. And in the CAR-T setting, we see, in addition, we have lymphodepleting chemotherapy, and because of higher incidence of CRS and ICANS, so these patients end up receiving more steroids and the cytokine block. For the comparison sake, if we see the burden of infections, so they are around, the overall infections are around, I would say, 50 to 60%. And if we look at the grade 3 or more infections, so they are around 20 to 25%. But with the bispecifics, this number is quite bigger. So, and the burden of infections is also class specific. So BCMA CAR-T, BCMA bispecifics, the overall infections are close to 80%. And if we look at the incidence of grade 3 or more infections, so they reach almost 50%. So that means 1 out of every 2 patients who is receiving BCMA bispecifics for a longer period of time is at the risk of getting hospitalized for severe infections. Comparatively, the GPRC5D infections, the overall incidence is around 50 to 60%, and grade 3 or more infections are also lesser, around 20 to 30%. If we look at the infection-related mortality, so it is variable from 2 to 10%, and that can be explained because of profound neutropenia, which reaches around 50 to 60% with these bispecifics, and hypogammaglobulinemia, which is around 70 to 80%. The other aspect is the pattern of infection. So we know that in BCMA CAR-T therapy, the infections are phase specific. So in the early phase, we are more bothered by the bacterial infections and sepsis because of neutropenia and the steroids that these patients receive. But subsequently, we see more of viral reactivations and opportunistic infections. And beyond 6 months, there is gradual immune recovery that we see, immune reconstitution that we see in these patients. But that is not the case with bispecific. So there is no plateauing of infection risk in the bispecific antibodies. We continue to have cumulative increase in infections. And there are basic caveats for this comparison. So the prophylaxis implemented with CAR T cell therapy when these trials were started, so we had some background wisdom from CD19 CAR T experience. There has been a learning curve with bispecific before integration of prophylactic strategies like IVIG. And we should also acknowledge that these are different study populations. The bispecifics receiving patients are probably more sick, and they are probably having a rapidly progressing disease. The other aspect of BCMA versus GPRC by 5D bispecific infection is that the BCMA is expressed not only in plasma cells, but it is also expressed on B cells and the precursor B cells. So unlike GPRC 5D, which is like more or less like more concentrated on plasma cells, so longitudinal monitoring shows that rapid and persistent depletion of B cell subsets in patients treated with anti-BCMA specifics. So the hypogammaglobulinemia is more prolonged and protracted with BCMA target. With GPRC5D, we see a gradual recovery after a few months. So that is one of the fundamental differences between these bispecifics. Nevertheless, we now know from the trials that anti-GPRC5D bispecifics, although they have lesser infections, but they are not safe. So they are relatively safer as compared to the BCMA bispecific, but they are not safe. And there are multiple reports of opportunistic infections, including rare infections like JC virus with these bispecifics. Can we predict infection risk? So there is some data that the risk factors associated with the infection. So they are the type of target, whether we are using a combination of bispecific with another bispecific or a CD38 monoclonal antibody, the high dose of steroids for CRS or ICANS, which if a patient receives that, then he or she is at higher risk of infection. Use of tocilizumab, more than 1 dose for CRS, and high hematotox score, which is based on platelet count, neutrophil count, CRP, and ferritin, that was used for CAR-T toxicity. Let's focus on the immunoglobulin replacement. So IVIG is the most actionable intervention, I would say, in the setting of bispecifics. It significantly reduces the infection-free survival, and it has been seen that there is 10-fold reduction in the overall risk of infections with primary IVIG prophylaxis. And I would like to highlight this slide from the Majestic-3 data that showed that before the institution of IVIG prophylaxis, the number of deaths were more in the Tec-DARA combination arm as compared to DARA-POM-DEX. And with the IVIG supplementation, this drastically reduced the number of deaths in the Tec-DARA combination. So that shows that the risk of infections with the bispecifics is modifiable. And as we increase the intensity of immunotherapy, that has to be accompanied by parallel intensification of the supportive care. If we look at the other novel agents, specifically the CD38 monoclonal antibody, we know that the relative risk does not reach the infection rates that we are currently seeing with the bispecifics and T cell redirecting therapies. And the infection related mortality across the trials with CD38 monoclonal antibodies is less than 2%. So to summarize the infection risk, so it is modest with proteasome inhibitors, IMiDs, and CD38 monoclonal antibodies. It is further increased by CAR-T and GPRC5D. But on the top of the ladder, they are bispecific antibodies, which are focusing on BCMA. So as far as the prevention of infections is concerned, so it is now more or less guideline driven. There are multiple consensus statements available. And we can summarize the prophylaxis as 4 pillars. So these are screening for infections, cytopenias, and hypogammaglobulinemia. The second component is antimicrobial prophylaxis, particularly against HSV, zoster, and the PJP. The third is the IVIG prophylaxis, and fourth is vaccines. So it is common across the consensus statements that these patients should receive acyclovir and ceftriaxone prophylaxis for the duration as long as they are on the bispecific continuous treatment. CMV and Hep B, we need to screen them, and we need to monitor these patients in high-risk subgroups, especially for the patients who have CD4 less than 200 and who have received significant steroid exposure. Antifungal prophylaxis is not universally recommended, but for the patients who have persistent neutropenia, ANC less than 500, and who have received heavy steroid dose, they should receive fungal prophylaxis. And antibacterial prophylaxis in the form of levoflox may be considered for the patients during the first month when the ANC is less than 500. The IVIG prophylaxis, as highlighted earlier, so previously we used to have a preemptive approach, and we used to replace immunoglobulins when the IgG levels were less than 400. But now there is data to suggest that primary IgG prophylaxis is more beneficial in terms of risk of reduction in severe infection. And it is also because of the concern that accurate IgG assessment in about half of these patients is incorrect, and patients may still have severe infections with normal immunoglobulin levels. So preemptive approach is more complex. Having a primary IVIG replacement approach, making it a more proactive approach, is something that is now more or less becoming standard of care. Vaccinations for these patients should be the vaccination status as far as influenza, pneumococcal, the zoster vaccines, these are concerned. So they should be optimized, and they should be boosted whenever we get any window during the post-treatment phase. And still, despite discussing all these aspects of bispecific therapy, so there are still unanswered questions whether we can achieve a functional cure, how to sequence them, how to mitigate the infection risk without compromising the efficacy, continuous versus fixed therapy, and how to overcome resistance. So we now know that from the MajesTEC-1 data that less frequent dosing leads to less immune suppression and less infection. And this is something that ultimately our patients would like. So they would like to have lesser hospital visits, and so that it is lighter on their pocket, and their safety is, I would say, it is better with the less frequent dosing. We had one poster in the last ASH called Limitech study, which focused on the limited duration of teclistamab, and it included patients who had achieved VGPR or better after 6 to 9 months of therapy. And what they saw that the median, after a median follow-up of around 12 months, the median PFS after enrollment was close to 20 months. And there were around 70% of the patients who were disease-free at 12 months after enrollment. So we can, drawing a conclusion from this study, so in a select subgroup of patients who are in remission, and especially maybe MRD negative, so they may be considered for a kind of treatment-free interval for bispecifics. So this is how the early relapse treatment paradigm is going to look in near future. For the patients who are DARA sensitive, they might be considered for either DARA tech or something like DARA plus talquetamab combination. For patients who are refractory to both lenalidomide and daratumumab, may be considered for either bispecific monotherapy or CAR-T. So which one is best for the early relapse? So the answer is not clear yet. So we have very promising data from the CARTITUDE-4 study that favored the efficacy of CAR T cell therapy in the early relapse setting. But we should know that apart from the infrastructure, there are concerns with the delayed neurotoxicity, cranial nerve palsies, Parkinson-like movement disorders, and second malignancies with the CAR T. And on top of that, we have teclistamab, which requires continuous treatment and is limited by infections and hypogammaglobulinemia. So how to choose bispecific versus CAR-T? So I think, first of all, I think we should not look them as a choice, and we should look them as as complementary options as far as treatment of multiple myeloma is concerned. So CAR-T may be more suitable from the patient perspective, someone who is fit, someone who is far, and who is more interested in fixed duration and treatment-free interval. And for patients who are frail, who are willing for recurrent hospital visits, chronic visits, they may be someone who may be more suited for the bispecific. And patients who have more aggressive disease, they might not be good candidates for CAR T cell therapy, and they shall be the ones who shall benefit from the bispecific therapy. There is a lot of debate that the autologous transplant should be out of multiple myeloma treatment, but we should acknowledge and look at the outcomes of multiple myeloma trials focused on CAR T and bispecifics. The non-relapse mortality as far as CAR T is concerned is 6 to 15%. And most of this NRM is contributed by infections. And if we look at the registration trials and the follow-up trials with BCMA bispecifics, this NRM is 1 to 8%. And in most of the hospitals, I would say in India as well, then the transplant-related mortality with the autologous transplant is, I would say it is less than 2%. So I think these immunotherapies, they are quite efficacious, but we should not we should not overinterpret the efficacy, and we should equally weigh in the safety concerns. This is the systematic review led by my colleague, Dr. Charanpreet, and beyond ICANS, there are neurological toxicities with CAR Ts, and in around 70% of patients with cranial neuropathies, movement disorders, and cognitive personality changes. So a significant proportion of these patients may be disease-free, but they may have irreversible, I would say, side effects that may severely compromise the quality of life. As far as IMWG recommendations for sequencing are concerned, so the IMWG is quite clear that for the patients who are eligible for both CAR-T and bispecific antibodies should receive CAR-T first, given the long-term durable responses that have been seen in patients, and because it is a one-time therapy. And if we have to take a choice between bispecifics versus antibody-drug conjugates, so bispecifics should be preferred over antibody-drug conjugates like belantamab. And this is based on the data that use of bispecifics before CAR T cell therapy, it significantly dampens the benefit that is probably seen with the CAR T cell therapy. And this is something that was highlighted in CARTITUDE-2 trial. Although this number is, this conclusion is based on very small data, which is like 7 patients. And I think this recommendation of CAR-T before bispecific was made when the approvals were there in the later lines of therapy, and we didn't have results from Majestic 9 and Monumental 3. And we can use bispecifics after CAR-T cell therapy with an overall response rate of close to 50%, which is still quite meaningful in this patient population. And it is true for both teclistamab as well as elrantamab. Second question is when to use teclistamab versus talquetamab. So I think for the patients who are at significant risk of infections, talquetamab seems to be safer. For patients who are thin and lean, low BMI, they may be someone who maybe like further, I would say, compromised by the weight loss and the dysgeusia which is there with the talquetamab. So in those patients, teclistamab may be better. For patients who have previously been exposed to BCMA, so I think may be better than teclistamab. And if the patient is BCMA naive, so either of the two, because using talquetamab before BCMA bispecific CAR-T is something that makes sense because the antigen target is different. Coming to the Indian scenario, so we have teclistamab since September 2023. Eldentamab was made available since June 2026. Talquetamab, we hope shall be available in next few months, and we do not yet have a commercially available BCMA CAR-T. So I think the question in Indian scenario among the bispecifics would be between Tecli versus Eldentamab. So we have different step-up dosing strength and the full doses. I think because the teclistamab is weight-based, so for patients who are more than 100 kilograms, so in those patients, because eldentamab is fixed dose, so that may be like, I would say, cheaper. In the initial 3 months, although monthly cost of teclistamab is something that is 1:1 patient is program. So that would, I would say, that would almost equalize the monthly cost of these two molecules. And I think depending upon the scenario where the patient is being treated, the vial sharing is something that can probably bring down the cost. Last couple of slides. So this is the role, the teclistamab's role. We published this case report from PGI, where the the patients were treated with the DARA BRD initially. Ultra high risk patients, they were they were having refractory disease, but with the treatment of with teclistamab, they were brought into remission and subsequently taken up for transplant. And this is something that that can, I would say, be a different aspect in lower middle income country where we still want to have transplant in the treatment algorithm, and limited duration of teclistamab is something that can bridge the pre-transplant management. I would highlight the treatment resistance mechanism. So we know that around 40% of these patients have primary resistance. I'm talking in the context of BCMA bispecifics, and now we know that bispecifics with the different immunomodulatory drugs, especially CELMoDs, IMiDs, checkpoint inhibitors, there is emerging data where we can use them for overcoming the resistance. And this is something that that is quite intriguing. Plasmapheresis is something that we can use for removal of excessive soluble BCMA that may be acting as a decoy for the bispecific. And recently we have used it in one of our patients. So this is the case report which was published in leukemia, and here the patient was treated with the VDD pace and followed by plasmapheresis, and then again treated with the bispecific, and that restored the sensitivity. So I think these are the ways which are like quite, I think, doable in the lower middle income country. And we recently had a patient where we adopted this strategy, and we achieved a response. So where the field is heading, so I think I would be brief in this regard. So we have like tri-specific antibodies which are targeting dual antigens that overcomes the possibility of single antigen risk escape. We have novel targets in like integrin B7 and other myeloma restricted antigens. In vivo CAR generation is something that is coming up. We had an oral presentation in ASH last year. 4 patients with in vivo CAR, they were all, they achieved MRD negativity, and the use of biomarker guided therapy. So MRD driven de-escalation and stopping, and soluble BCMA and relapse target profiling is something that is coming up. So this is the slide summarizing the journey of teclistamab, and through either in the form of monotherapy in the relapsed refractory multiple myeloma, and now it is being used in combination with other molecules like DARA and lenalidomide, not only in the early relapse, but in the post-transplant maintenance. And now we have like phase 2 data in the newly diagnosed setting where all the patients with who were treated with monoclonal with the monotherapy teclistamab, they achieved MRD negativity. So I would conclude by saying that bispecifics have fundamentally changed the expectations as far as management of relapsed multiple myeloma is concerned, and they have off-the-shelf convenience, and they provide deep and durable responses with high MRD negativity. We have randomized trials that show that the PFS and OS benefits are transformative in as early as first relapse, and it is not just a salvage option. The CRS is not the main problem. The main problem is the issue is the infections, and we should treat these patients in a setting where they receive supportive care in the form of prophylaxis, IVIG, and vaccines. And with the appropriate patient selection and supportive care, I think they are going to be become an important component of multiple myeloma therapy, not only in relapse setting, but in the newly diagnosed and post-transplant setting. So with this, I conclude, and I would be happy to take questions. And it gives me immense pleasure to invite all of you for Indian Myeloma Congress, which we are going to hold in PGI Chandigarh from 12th to 14th Feb 2027. Thank you.
Thank you, Aditya. Wonderful lecture, beautiful update, a lot of learning, and you made it very simple also for everybody to follow. We have a couple of minutes available to us if there is anybody having a burning question. He explained everything so nicely.
Thank you, sir.
Just one question. In your practice, what do you do about reducing the frequency of administration of these drugs? If somebody has achieved almost like a MRD status, then you reduce, or you do it by any other method?
So, sir, what we are doing right now is that for the initial 1 month, or maybe I would say because the median, we have seen responses as early as 1 month after the initiation of therapy. So most of these patients who are like achieving CR by an end of 1 month or in at the end of 2 months. So we go ahead with the MRD assessment and PET scan if the patient had extramedullary disease. And if the patient's the MRD is negative, then we switch to either once in 2 weeks or once in a week. So in fact, we have a patient who received just 4 doses of teclistamab in October 2025. We had to discontinue teclistamab because of recurrent respiratory infections, and I saw him last week. He's still in stringent CR and MRD negative. So I think the trajectory of the disease is something that is quite, I would say, variable among the patients as well. And I think we need to take decisions on case-to-case basis. But mostly we take decisions by the end of second or third cycle.
And do you practice fixed duration therapy? Do you stop somewhere?
So right now we are not doing that, sir. The patient with the longest follow-up that we have right now is someone who was started in December 2023. So he is almost like 2.5, I would say,
1.5.
almost 2 years, because there was an interruption in between. So for that patient, because of infections, there was interruption, and again there was relapse. Fortunately, he responded with the re-challenging him again with the teclistamab. So as a protocol, we are not following a fixed duration, but I think as we um, I hope that we have more data in this domain apart from Limitech and uh, uh, other trials where putting patients off the therapy was not because of infections, but it was like part of a randomized trial. So I think that would be more convincing.
One quick question with a quick reply. How long do you continue IV gamma globulin if you stop teclistamab or lenalidomide?
So right now, sir, we have, I think, as long as the patients are receiving teclistamab, so they are on primary IVIG prophylaxis monthly. And subsequent to that, I think we continue to monitor monthly the immunoglobulin levels. So as long as they are going to have IgG levels less than 400, they shall be continuing to receive IVIG prophylaxis.
Thank you so much, Aditya. It's almost 7:30. There are some questions in the chat box, but probably you can just answer them in the chat box.
Sure, sir.
We'll move to the second web lecture. It's my pleasure to introduce my another friend,
Thank you, sir.
Manish Badgett from Melbourne, Australia. He is already logged in. We heard him multiple times in last couple of years. Wonderful speaker and has educated us in various aspects of recent advances in hematology. Uh, he is associate professor, consultant hematologist, and BMT physician, disease group co-lead acute leukemia and MDS, Peter MacCallum Cancer Centre, and Royal Melbourne Hospital, Melbourne, Australia. Graduated from University of Mumbai, India, followed by specialist training in internal medicine and hematology, culminating in DM in clinical hematology. He subsequently obtained fellowship of the Royal Australasian College of Physicians and Pathologists in clinical and lab hematology. He is actively involved in clinical research as a principal investigator and associate investigator of clinical trials focused on novel drugs and cellular therapies in acute leukemia and alternate donor transplants. He's a peer reviewer for multiple hematology journals and associate editor for the journal Transplantation. He's on the board of directors of the Australasian Transplant and Cellular Therapy Society. Today he's going to speak to us on another wonderful immunotherapy, that is CAR T cell therapy in acute lymphoblastic leukemia. I'll stop here and hand over the platform to him.
Thank you, sir. I'm just trying to see if I can share my slides. I'm just having some difficulty in sharing the slides. Let me just see if I can get across this. Just give me a minute and I'll try to. I'm not sure. I'm having some technical hiccups. I might have to log off and log on. I just can't get a share function to work on my.
Will you like to email your presentation to our?
I can. I will just email it straight to you. Just give me a minute and I'll email it. I'm sorry about this inconvenience.
Kalpesh, can you type the email ID? Right, that's the email ID. You can forward your presentation to him and he will run the show.
Just bear with me. It's just a large one, so I have to just send it across to Kalpesh in a different way. If you can hold on for a couple of minutes, I'll send it across. Yeah.
Okay.
I've just sent it across to you. You can is it working as a link? Just let me know. Is it letting you open it? Not letting you open it. Sorry, I'm just trying to work out why it's just blocking everything I'm doing here. Relax. Share. Copy then. Oh, sorry. Do you think if I send it to you as a PDF, it will work for you? Okay. Let me just try to convert it into a PDF and I'll send it to you. Sorry about this. It's just not letting me do anything here. Has it come as a PDF to you now?
It's on now.
I can control it. Thank you. I'm sorry about and apologies about this. IT always gets you, and so I'm sorry about this. So Thanks, Dr. Agarwal, for the wonderful introduction. I will be speaking today on CAR T cells and acute lymphoblastic leukemia. Next slide. I don't think the control is with me still, actually. Pardon me? Yeah, I think that might be easier. Next slide, please. Those are my disclosures. Next slide, please. So today I'll be discussing on CAR T cells. I'll give a brief introduction on what CAR T cells is. We'll speak on the clinical trial data that's available in acute lymphoblastic leukemia, move on to what the real world data is, the practical considerations, and then discuss a bit on what are the predictors of response and survival, and where is the field of CAR T cells, at least in acute lymphoblastic leukemia, going to. Next slide, please. So as you're aware, CAR T cells is adoptive cellular therapy. Essentially, the CAR or the chimeric antigen receptors, these are synthetic receptors that have got the specificity of a monoclonal antibody. So like a monoclonal antibody, they've got a heavy chain and a light chain. They then have a signaling domain that causes the activation of the cell. The most important thing about the CAR T cells, which are genetically modified cells, is that their activation is not dependent on the HLA presentation of a peptide. And this is different from activation of the normal T cell. However, the immunological characteristics are pretty much similar to an activated T cell. The immune response and the expansion is similar to what happens with the activated T cell. Next slide, please. The research in CAR T cells is moving at a pretty rapid pace, and you did hear earlier on in the topic on bispecifics on multiple myeloma that we have got almost in vivo CAR T cells, but these have gone through generations of development. And we started off with the first generation, of which was the simple, just a chimeric antigen receptor with a signaling domain. The second generation CAR T cells had a co-stimulatory domain, which enhanced the stimulation of these CAR T cells. The third generation had two co-stimulatory domains. And then we started going into the trucks kind of CAR T cells where they would have additional interleukin inducers put in there, which would further activate the cells. Additional activation of pathways, including the JAK pathway and the STAT pathway on the fifth generation CAR T cells. When we think about CAR T cells, they can differ in terms of the antigen binding, the epitope that they're binding on, the affinity of the cell. The structure could vary. They could be humanized. The co-stimulatory molecules could vary, and these co-stimulatory molecules are responsible not only for the function, metabolism, but more importantly for the persistence of the CAR T cells. And this will be evident when we discuss the different products of the CAR T cells that are available. And the activation mechanisms, depending on whether the additional pathway is getting activated, could result in more proliferation of the cells. There could be differences in how the CAR T cells get manufactured based on how we transduce the chimeric antigen receptor into the CAR T cell, what sort of vectors we use, what sort of co-stimulatory domains we use, and of course, most importantly, what sort of antigen specificity, whether we look after a single antigen or whether we after two antigens, and whether some of these antigens can bypass pre-existing resistance to some other antigens. Next slide, please. Now, what do CAR T cells actually do? So simply the CAR T cells, because they are almost similar like the T cells, once they see the antigen, will link onto the antigen. There will be downstream activation of the cell. This activation of the cell will not only cause the proliferation of that cell and expansion of the cell, but will also release certain chemicals, which are the pro-inflammatory cytokines. And these will then result in exocytosis, release of perforins and granzyme from these activated CAR T cells and cause cell death. So it's pretty much like an activated T cell, but without the need for an HLA to happen. Next slide, please. The CAR T cells, as we understand now, are most commonly the autologous CAR T cells. We can have autologous CAR T cells where we are taking the T cells from the patient themselves, or we can have allogeneic CAR T cells. And the field of allogeneic CAR T cells has probably not developed to that extent as autologous CAR T cells. So essentially, the process is cumbersome at this point of time. We subject the patient to leukapheresis, take their lymphocytes, we activate and transduce these lymphocytes, we expand these lymphocytes or the CAR T cells. We then expose the patient to chemotherapy, which we call lymphodepletion chemotherapy, and finally we give the CAR T cells to these patients, which these CAR T cells which have been manufactured and cryopreserved are infused back to the patient. Next slide, please. Once we have given the CAR T cells, then we have to prepare for the effects of these CAR T cells, and we are familiar with some of these cytokine release syndrome, and this particular graph gives you the timelines of these side effects that we encounter. The risk of hemophagocytosis, neurotoxicity, which is also caused as ICANS. With the BCMA CAR T cells, we are seeing some late toxicities with the movement disorders. We can get heme toxicity or persistent cytopenias or an inflammatory signal that can develop. And of course, when depending on the kind of the CAR T cell using, if we are using something that's targeting the B cells, we'll end up with B cell aplasia, hypogammaglobulinemia, and the risk of infections. Of course, one of the signals that's now slowly picking up or slowly being picked up, and especially we've seen this in the lymphoma CAR T cells, and some of my colleagues have actually presented this in ASH, is as we have patients surviving after the CAR T cell therapy, and especially patients who've been multiply treated, we are seeing some secondary heme malignancies in these patients, and we have started seeing a small burden of patients where we are seeing post-CAR T cell related myelodysplastic syndromes and acute myeloid leukemia in these patients, especially patients who have pre-existing P53 clones. So this is the burden of the side effects. And I think the whole field of CAR T cells is now moving not only to improve the efficacy, but to reduce the toxicity that we are suffering from these CAR T cells. So we want the most effective and the least toxic CAR T cells for our patients. Next slide, please. Now, the whole story of the modern CAR T cell started from this patient, Emily Whitehead. And she was the patient that has been cancer-free for many years. Now it's almost more than 15 plus years that she's cancer-free. But she was a pivotal case that has moved the field and has advanced the field to that extent. And I think it's important to remember that we are talking of CAR T cells and lymphomas, myeloma, but it was ALL that actually drove the field by a single patient who was very successful with the CAR T cell therapy. Next slide, please. Now, immunotherapy in BALL is not a new concept. It's an age-old concept in BALL. We have always known immunotherapy works, and we knew it from the time of allogeneic stem cell transplant. We got more familiar with immunotherapy by the use of rituximab. Blinatumomab is the most prominent of the immunotherapy BiTE molecules that we are using. We've got drug-conjugated antibodies with inotuzumab. And then we've got the cellular immunotherapy, which is CAR T cells. And we'll speak a bit about how these treatments like Blin and INO, which are now moving into upfront of ALL, have a bearing on what we can expect in terms of efficacy of CAR T cells. How do we position these molecules and treatments, especially when we are moving our patients to CAR T cells? Next slide, please. So if you look at the approved CAR T cells available, and I'm now at this point of time talking of what's available globally in terms of CAR T cells. I will discuss what's available in India on a slide, but what's available globally are these three CAR T cells. Tisagen, which is called Kymriah. It's a autologous CAR T cell. It's against CD19. It's got 4-1BB as the co-stimulatory molecule. And it's approved for patients with B lymphoblastic leukemia who are aged less than 26 years with refractory or multiply relapsed disease. The next CAR T cell that's available is Brixucell, which is also called Tecartus, and it's against CD19. The co-stimulatory molecule here differs. It is CD28. Now, this different co-stimulatory molecule is responsive for a bit more explosive proliferation and expansion of this CAR T cells, but the persistence of this CAR T cell, because of the CD28 co-stimulatory, is not as good as the ones that have got a 4-1BB domain. Now, this is approved for adult patients with relapsed or refractory leukemias. Doesn't have an age limit, but in Australia, it's approved for only patients who are older than 26 years. The last CAR T cell on the block that's been globally approved is Obe-cel, and it's also called Otac-cel. It's again a CD19 CAR T cell. It's got a co-stimulatory domain of 4-1BB and is approved for adult patients with relapsed refractory BAL. Now, the reason this is being highlighted differently is we in Australia, we do not have this available yet. But of all the three CAR T cell products, this by far looks to be the safest CAR T cell with the risk of CRS and ICANS being less than 10%. So the risk of serious CRS with obe-cel is around 3 to 4%. The risk of ICANS is around 7 to 8%, which is much lower than what we are seeing with Tisacin, but more importantly, which is much lower than what we are seeing with Dixucel or Tecartus. The reason obe-cel is more safer is because it's got a fast off, so the CAR T cell does not remain bound to the leukemia cell for a long time. As a result of this, the CRS is less. And they also have an interesting split dosing strategy, which helps reduce the risk of toxicities in these patients. Next slide, please. Now, CD19 is the most rational T cell national target for B-cell ALL, and that's because it's pan-expressed across the whole ontogeny of the lymphocyte, and hence it's applicable, anti-CD19 CAR T cells applicable not only in leukemias, but in a wide spectrum of lymphomas, where it actually is effective in killing the tumor cells. Next slide, please. So let's look at some of the clinical trial data that has got some of these CAR T cells approved. And we'll start with Tisagin, which was approved for patients who are less than 26 years age with a relapsed refractory B-cell ALL who are expressing CD19. And the pivotal trial that was responsible for approval was the Ileana study. Now, this was a phase 2 study. The phase 1 work was already done, and it showed that these 60 to 70% of these patients would achieve a CR. The 12-month OS was around 60% in this group of patients. But the Ileana was different from the phase 1 study because for the first time, they ran a global trial. They tested the whole philosophy of actually collecting the cells, transporting the cells to a central manufacturing facility, then transducing, manufacturing the product, cryopreserving, and then sending the cells back to the patients, and just establishing the paradigm that we are following for the CAR T cells right now, where we have got central manufacturing facilities. They started off with 107 patients, 92 of these were enrolled, and eventually 75 of them underwent the infusion. Now, that's important to remember that there seems to be a bit of drop-off, and one of the challenges in moving the patient from identification to the infusion of CAR T cells is actually being able to keep them stable enough to receive the CAR T cell infusion, and also being ending up with the product, not ending up with manufacturing failure. So 75 of these patients underwent the infusion and 48 remain in follow-up. And if you look at the median time from enrollment to infusion, median time was 45 days, so varied between 30 to 105 days. And if you recall, this was with the first global trial that established that whole paradigm that we could collect cells, transport cells, manufacture cells, and transport it back, and still keep the patient safe enough to actually infuse in a very proliferative leukemia. The median age was 11 years. The median treatments these patients had received was 3. And 61% of these patients had a prior allogeneic transplant, though the trial excluded any prior CD19 therapy. So patients who had received blinatumomab did not go on this trial. Next slide, please. Now, if you look at the survival of the patients who had this, and we had a heavily pretreated group, out of the 75, the median overall survival was 19.1 months. The event-free survival was not reached. And if you look at the 6-month survival, 90% of these patients were surviving, and event-free survival was 73%. Now, not only was the impressive outcome in terms of survival, there was a durability in the response, and the median duration of remission was not reached on the Ileana study. Now, just to remember, this product had a 4-1BB, so the CAR T cells persisted. Next slide, please. If you look at the adverse effects, the predominant ones, the ones I discussed earlier, the cytokine release syndrome, the neurological syndrome, evidence syndromes were there. But if you look at the serious side effects, the CRS was still high. You were getting CRS in around 40% of the patients. That was grade 3, grade 4. Now that is quite a serious CRS. And one thing to remember is when the Ileana trial was actually published, we did not have standardized criteria to grade CRS. So the CRS criteria were graded on a different criteria. The neurological toxicity was much lower, was 13%. As expected, patients had cytopenias, had infections. A very small proportion had tumor lysis syndrome. Next slide, please. In terms of biomarkers of persistent, the phase 1 work with this product had already established 2 possible biomarkers to look at. And this formed the basis of what we now consider for, and when we look at other CAR T cell products. One is to look at the persistence of the CAR T cells, and because they had a 4-1BB co-stimulatory domain, these CAR T cells actually persisted longer, and 68% of these patients had CAR T cells persist beyond 6 months. The next functional marker to look of or a surrogate marker to look about the ongoing efficacy of the CAR T cells is B cell aplasia. And they define this as less than 3% of lymph cells that have been presented in the blood. And 73% of the patients at 6 months had a B cell aplasia. Of course, these patients, by the virtue that they required B cell aplasia, needed immunoglobulin supplementation. But the B cell aplasia in the 4-1BB CAR T cells was a robust marker of the functional efficacy of the CAR T cells. Next slide, please. So based on this, we had the approval and the registration of young patients younger than 26 years who had a refractory or a relapse of acute leukemia after transplant, or who were in second or later relapse. Next slide, please. The next CAR-T product which has been approved is the Brexucel, and the Brexucel was approved based on the ZUMA-3 study. They had already done the phase 1 work. Now I'll remind you that this is a slightly different CAR-T product. Though it still targets CD19, it has got a CD28 co-stimulatory domain that results in a shorter persistence of the CAR-T cell. This is the scheme of the trial. The patients got allowed bridging therapy. They had lymphodepletion with fludarabine cyclophosphamide, and then had a fixed dose of Brexucel given at 1 million CAR-T cells given on day 0. And the key endpoints that they were looking for was the efficacy in terms of the overall CR rate, CR plus CRI, duration of response, overall survival, and MRD negativity rate. Next slide. Now, I've deliberately put this flow chart, and I know it is confusing, but I wanted to highlight a few points. The boxes in the blue are a combined phase 1, phase 2 data, but on the orange are the boxes that tell us about the phase 2 data of ZUMA-3, where this trial received approval. Now, one of the questions that we will be discussing later is allogeneic transplant and what's its role with CAR T cells. And I just want you to follow the orange boxes. And if you look at these boxes and see that the phase 2, they started off with 55 patients here on there. And then when they looked at the primary endpoint, 39 of these patients had achieved a CR/CRI, which is fairly impressive. But as you go down to the 3-year follow-up, you start realizing that there are patients who went to have allogeneic transplant, there are patients who started different treatments. And when we actually look at the cohort of the patients who did not have an allogeneic transplant, by the time they were at 3 years, there were only around 4 patients who never had an allogeneic transplant and were still in ongoing remission. Now, the numbers are a bit disappointing in the sense that the drop-off is large, but it's important to remember that this was a phase 2 study. We are looking at an indication or a patient population that did not have any treatments that would help them get in remission. So the mere efficacy of this treatment was sufficient to actually get approval as registration. But when we put it into practice, we have to be mindful that this might not be a standalone therapy, and we have to be careful about identifying patients who may still benefit from an allogeneic transplant or other strategies to consolidate their response. Next slide, please. So if you look at the 3-year follow-up, the median overall survival of this patient at 3 years was 26 months. The overall survival rate at 3 years was 47%. Now, this is, in terms of numbers, is pretty comparable to what we see. But you have to recall that they're talking of overall survival. They are not talking of event-free survival here, which means there were patients who would have undergone and received further different treatments if they had MRD relapse, or they had a morphological relapse, or may also include patients who have allogenic stem cell transplant. Next slide, please. If you look at the toxicities, again, you're seeing the prominent toxicities are CRS. More than 24% of the patients had grade 3 CRS. This is more contemporary classification of the CRS and the ICANS. In terms of the neurotoxicities, I think you will see the numbers are a bit higher. The grade 3 neurotoxicities are 25%. And that's because of the nature of this product, which is highly proliferative and expands. Though it does not has got shorter half-life as compared to the 4-1BB CAR T cells. So grade 3 or higher neurological toxicities were in 25%. They had one death because of brain herniation to this. Tocilizumab, which is a common thing that we use for CRS, was used in almost 80% of these patients. Next slide, please. So this ended up with the registration of this in patients who were, at least in Australia, is only for patients who are more than 26 years, morphological disease, CD19 positive disease, and they could either be primary refractory, they could have had their first relapse within 12 months, or they could be relapsed refractory after 2 lines of treatment, or relapsed refractory after an allogenic transplant. Next slide, please. So having discussed the real trial, clinical trial data, let's move to what the registries tell us about these products. And this is the registry data from the CIBMTR about the Kymriah. And you'll see that the registry data pretty much actually reflects what was found on the clinical trial. This was the registry data on 159 patients. Again, the number of median treatments is 3. The median age is around 12 years. So pretty much similar to the Ileana study. Only difference in real world, they included patients who had blinatumomab. So there was a small cohort of patients who had blinatumomab. 1/3 of these patients had a prior allogeneic stem cell transplant. Some of the patients had CNS disease and others had extramedullary disease. Less than 10% patients were Philadelphia positive. Next slide, please. The median follow-up is short, but again, if you look at the 6-month duration of response, the event-free survival at 6 months, the overall survival at 6 months, these numbers pretty much mirror what was seen on the Ileana study. So it was reassuring that when they brought the same paradigm of treating patients in real world, the registries recorded the same degree of efficacy that was recorded on the Ileana study. The grade 3 CRS was more controllable, again, more contemporary reporting, just 13%. Grade 3 ICANS was less than 10%. So this was very promising in terms, and when it was reported by the registries that the data was pretty similar to the trials. Next slide, please. And when we look at the data of the registries for the Brexucel, which is the Tecartus product, again, the overall CR rate was 79%. And 66% of these patients were not in CR/CRi prior to infusion. If you look across all the age groups, the prior blin exposure, prior allogeneic transplant, extramedullary disease, we see that the product was effective. Again, reassuring us in terms of what was seen on the registry data as compared to what was seen on the ZUMA-3 trial. Next slide, please. When we look at the 6-month relapse-free survival was 56%, the 6-month overall survival was 79%. Again, in terms of the short follow-up, looking at the ZUMA-3, now this was not long follow-up. The ZUMA-3 went on reported 3-year follow-up. The registries have still not reported that longer follow-up yet. But this was reassuring that it pretty much mirrored what was seen on the clinical trials. Next slide, please. Now, when we think of putting this in practice, the CAR T cell is actually a continuum, and I've just put out what we would follow in terms of preparing a patient for CAR T cells. We'll get a referral, we'll consent the patient. The patient will have to undergo leukapheresis. The patient will undergo screening for organ function. We have established and defined guidelines about which patients would be suitable for CAR T cells, not only in terms of the performance score, but in terms of the cardiac function, the renal function, and ongoing infections. In patients who are allogenic transplant, they should not have GVHD and they should be off immunosuppression. Patients would require bridging therapy, lymphodepletion therapy, infusion, and then long-term follow-up. Now, along this line, at the bottom, you will note that there are things that we have to contend with. When we are getting our patients ready through leukapheresis, screening, other stuff, we have to keep an eye on the disease and prevent disease progression. We have to contend, although we are lucky that the risk of manufacturing failure is low, it does happen in occasional patients that we end up with a manufacturing failure. And that has to be a part of the consent of our patients, that sometimes there could be a manufacturing failure, or we get an out-of-spec product from them, and we have to make a clinical decision whether we are going to go about infusing that product. And last is the toxicities that come along with CAR T cells that we are all familiar with, which I previously have discussed. Next slide, please. So let's start discussing some practical issues and consideration around the apheresis, the bridging therapy, lymphodepletion, monitoring post-CAR T cells, which is very important, predictors of survival, transplant, and think of bit on relapse and where the directions are going further. Next slide, please. So when we think of apheresis, we have to take into account what treatments the patients are coming off. And there has to be a good washout period. There are guidelines from the American Society of Transplant and Cellular Therapy about what sort of washouts are required for our patients. The most common washouts that we tend to continue our patients or tail our patients on is steroids, because you can switch off steroids 72 hours before, still keep the disease under control, and take the patient for leukapheresis. But if your patient is on drugs like aspergillase or is on other antibodies, there is required to be a washout of nearly 4 weeks on these patients. Inotuzumab is another drug, and we try to give a washout of at least 2 weeks for inotuzumab before we put the patient on leukapheresis. One of the reasons for washout is you would prefer having a lymphocyte count so that you have a successful leukapheresis on your patient, and hence the washout is not only important from getting the good quality of the T cells, but also actually having a proper washout. And sorry, I mentioned 2 weeks. Inotuzumab we stop only at 1 week, and we put our patients on the machine. Next slide, please. The next thing that we have to think of bridging therapy, and we've got options to use in terms of bridging therapy. These options could be chemotherapy. These options could be, and the chemotherapy could be gentle chemotherapy by just using steroids, vincristine, or drugs like 6-MP methotrexate. Or we could go for drugs like inotuzumab that we use for bridging therapy, which is becoming more and more popular. But there are obviously some concerns about inotuzumab that have been raised. We avoid using blinatumomab because we don't want to expose our patients to anti-CD19 products as a part of the bridging therapy. Moreover, also at the same time, we want to keep a safe interval between bridging and infusion. We don't want to our patients to get infections before they end up getting an infusion for the CAR T cells. So these are the various options, and we have to individualize these decisions. We have a weekly meeting for CAR T cell patients, and some of these issues we discuss in our meeting, and the decisions about bridging therapy have potentially been individualized. I guess in lymphomas, there is an advantage that sometimes we can use radiotherapy, but in leukemias, we have to use something systemic depending on the kinetics of the disease. Next slide, please. Now, inotuzumab is quite a attractive option to be used for bridging. The inotuzumab literature is a bit confusing, because if you look at the literature, there are studies that showing that inotuzumab is associated as bridging therapy is associated with reduced efficacy of the CAR T cells. And some groups have not found the same thing. They think inotuzumab can safely be used. This was a good study that was led by Ibrahim Eldos from the City of Hope, where they pooled together 189 patients who had received inotuzumab prior to CAR T cells. They split them into those who were INO naive and INO exposed. And those these patients who were INO exposed was the focus of this group. They split the patients into 3 different groups. Patients who were responders to inotuzumab, and patients who were exposed and non-responders to inotuzumab. And then again, you try to look at the survivals in terms of the progression-free survival and the OS of the survival after they got an infusion. The patients who got inotuzumab were not responders, seem to have the worst outcome as compared to the group that were exposed but did have some response to inotuzumab. In practice, we use inotuzumab, but international groups are trying to limit the degree of inotuzumab they're going to use for their patients. The reasons are they do not want to completely get the patients into a deep response with inotuzumab. They want some degree of B cells hanging around there to be a stimulus for the CAR T cells to have a proper expansion. So most groups would use either a single dose or 2 doses of inotuzumab, control the tempo of the disease, and then move quickly to an infusion of the CAR T cells. Next slide, please. Now, the importance of lymphodepleting treatment, and the paradigm here has been set in terms of using fludarabine and cyclophosphamide as the lymphodepletion treatment. And sometimes our patients have got borderline renal functions. We worry whether we should drop off the fludarabine, whether we should just give cyclophosphamide. There is a good rationale for using the lymphodepletion studies. Studies have shown that when lymphodepletion is omitted, that doesn't give a proper expansion of the CAR T cells or the persistence of the CAR T cells, and the overall survival is significantly reduced. So the lymphodepletion is pretty much required for the CAR T expansion and persistence. It also reduces the anti-CAR T cell immune responses, or prevents the rejection of those CAR T cells, and should be pursued. There should be a very good reason not to give lymphodepletion to a patient prior to CAR T cells for acute lymphoblastic leukemia. Next slide, please. Now, the most important thing is, how do you monitor your patients for CAR T cells? And I have put up here what we would usually do for monitoring our patients for CAR T cells. Our initial assessment of our patients would be 4 weeks after infusion of the CAR T cells. That would include a bone marrow. In patients who would have prior CSF disease, we would do a CSF on the patients, but we will not infuse chemotherapy because, as you know, CAR T cells find their way into the CSF, and provide a anti-leukemia benefit there. For patients who got extramedullary disease, we would do a PET scan. We have the ability to look for CAR T expansion, so we are able to identify that. Now, we don't act on that right now, but that information is useful for us to closely follow up our patients. As regards to bone marrows, we tend to follow our patients with clonoSEQ, which is got a sensitivity of 10⁻⁻⁶. So that gives us a lot of confidence about how deep our responses of our patient are once they are in CR. Additionally, one has to be aware that if you're using flow cytometry to monitor the MRD, the lab that's reading the flow cytometry should be aware that these patients have received anti-CD19 therapy, so the gating strategies have to be adjusted accordingly. The other parameters that we sell is we look at the B-cell aplasia and the IgG level. Now, our local protocol is we monitor at 1 month, 3 months, 6 months, and 12 months. And we tend to do marrows and follow MRD. We don't do clonoSEQ and all these time points, but we will do, follow with flow, and with at month 12, we will follow up with clonoSEQ as well. And these are important in terms of the timelines of making decisions whether we are going to consider an allogeneic transplant. The time point of 1 and 3 months are the most crucial ones. And if we are seeing an MRD signal still persisting at 3 months, we will consider an allogeneic stem cell transplant for our patients. The B-cell aplasia signal is quite strong in patients who get the Tecartus product, in those who get the Tisa-cel product or Kymriah, but is not as strong in patients who get the Brexucell because the CAR T cell does not persist for a long time. So we tend to follow the B-cell aplasia much closely in patients who are getting the Tisa-cel, the 4-1BB co-stimulatory product, but not to that rigidly to that extent in the Brexucell for making treatment decisions. Of course, the B-cell aplasia and the IgG levels are important to make decisions of immunoglobulin support and a replacement for our patients. Next slide, please. Now, what are the survival predictors of CAR T cells? And we'll start off with what's the impact of disease burden and MRD response. So studies across different groups from MSKCC, from the Ileana, from the Zuma3 have shown that patients who've got a much lower disease burden, and preferentially even patients who are in CR, and this has borne across the registry studies, also end up having a better response to CAR T cells. Now, one of the questions that's been raised is, how do the CAR T cells expand? Even patients who are in CR and even those who are in MRD negative CR have been shown in some trials to have an expansion of CAR T cells. So deeper the response the patient gets before the infusion of the CAR T cell, the higher is the chance that they will have a superior survival after the CAR T cells. Studies have also shown that if your patient is an MRD negative CR before infusion of the CAR T cell, then perhaps there is no role of allogeneic stem cell transplant. But we'll discuss that in the subsequent slides. Next slide, please. CAR T expansion. So if you're going to get a good expansion of the CAR T cell, and if you've got ability to measure that, that's a good predictor of what the survival of your patient is going to be after the CAR T cell infusion. And because we are documenting this, we are using this as one of the additional time points, additional bits of information in making decisions whether we are going to pursue an option of an allogeneic transplant in a patient. But having this test to look at the expansion and measure the expansion of CAR T cells is very helpful in making the overall treatment decisions of the patient. Next slide, please. There are some other predictors, and these predictors are related to the disease burden. For example, an LDH pre-lymphodepletion, which is a biomarker of the disease, and the LDH that's higher would result in a lower survival. Platelet count, the higher platelet count again would be associated with the higher survival, but a thrombocytopenia pre-infusion or pre-lymphodepletion would be associated with a lower survival. Overall, rapidly proliferating disease is perhaps not the best disease to take into CAR T cells because we've seen these patients fail. It's good to get a good control on the disease so that you have sufficient time for the CAR T cells to settle in, to expand and do the job. rather than get outrun by the proliferating disease. Next slide, please. I did mention heme toxicity as one of the toxicities that we've seen from the CAR T cells. And the CAR heme tox score is a well-established score that looks at the ANC, the hemoglobin, the platelets, inflammatory markers, CRP and ferritin in patients as prior to the lymphodepletion as markers of whether they will get prolonged cytopenia. The CAR heme tox score was established to understand or to predict patients who would be at risk for prolonged cytopenias. But studies have shown that they even correlate with the survival outcome of the patient. And if the patient has got a high CAR heme tox score, then that is of 2 to 7, that is going to be associated with the inferior survival. Now, if we combine the disease burden with the CAR heme tox score, we can now develop a bit of a risk score where patients who've got a high heme tox score, who've got high disease burden, are likely to have a much inferior survival despite the CAR T cell therapy. And perhaps these are the patients that we could consider a target for consolidative allogeneic stem cell transplant after the CAR T cell. Next slide, please. Prior blinatumomab, some of the other studies have shown, and these are not in large randomized studies, but some of the other studies have shown that prior blinatumomab failure is associated with a poor outcome with CAR T cells. Adverse cytogenetics is associated with a poor outcome with CAR T cells. A fatigued or exhausted T cell profile, where they have expression of LAG3 or they have a lower TNF profile, can be associated with the failure of the CAR T cells. And new studies are showing that certain CD19 isoforms and a certain bone marrow epigenetics may be associated with a poor outcome from CAR T cells. Next slide, please. So the big question now remains is, do we have given our patient the CAR T cells? The patient has benefit from the CAR T cells, is in the remission. We are following up our patients. What's the role of allogeneic stem cell transplant? And here it's important to remember that not all CAR T cells are equal. We've already seen that the 4-1BB co-stimulator CAR T cells are persisting longer as compared to the CD28 CAR T cells. There were a lot of studies done from NCI with the CD19 CAR T cell product, and their CAR T cell product was short-lived, and hence their algorithm was the patients would follow an allogeneic transplant. So it pretty much depends on what CAR T cell product you are using, whether allogeneic stem cell transplant is going to be a key component of the treatment journey of the patient. As I mentioned, 4-1BB CAR T cells persist longer. If you've got persisting B cell aplasia, especially with Tisa-cel, it's a functional or a pharmacodynamic equivalent of the persistence of the CAR T cell. So these are some markers for us to consider which patients would consider and should be considered for allogeneic stem cell transplant. Next slide, please. If you look across the studies, and these are various studies, I've highlighted the 4-1BB studies, and you look at the CD28 study. The 4-1BB studies with Tisa-cel, the incidence of a stem cell transplant is rather low, 10 to 13%. It's a bit higher in the studies that used a different product, but the studies that are highlighted in red are pretty much the Tisa-cel studies, and 10 to 13% patients only needed a transplant. The CD28 products, you can see that the incidence of transplant is high, just reflecting what goes on. The ZUMA-3 study, on the upfront, only 20% patients got transplanted, but you saw from the algorithm that I showed that patients went to other treatments or had subsequent relapses when they were followed up for a much longer time. Next slide, please. Now, if you look at the Brexucel, and this was, I just wanted to bring this up to, in a sense, critique this, that this was the ZUMA-3 late follow-up. And they did an analysis, and there is always a fault about doing an analysis on studies that were not originally designed for that question. So this study was never designed to answer the question whether allogeneic transplant would be required after CAR T cells. But they went ahead and they tried to answer the question from the limited cohort of patients that they have. And they came up with the answer that whether the patients had an allogeneic transplant or did not have an allogeneic transplant, the survivals looked the same in terms of the median survivals of 50.3 months and 60 months. Now, they were talking in terms of overall survival, so that does not really take into account the other treatments that the patient may have received. And what I've highlighted down for you is that when you're talking overall survival, you also have to look at the numbers that are at risk. And when you start looking at 3 years, you will see that the numbers drop in single digits. So the confidence that you have of saying that is rather low. It's not the study was not designed to answer this question, and the numbers that they're using to answer that question are very low. So I would take this with a pinch of salt. I don't think this is sending out the right signal. The right endpoint would have been a relapse-free survival. And you can look at the relapse-free survival. I don't need to describe the relapse-free survival. You'll see the curves drop down. So when we're talking of using Brexucel, we are using all the resources that we have to monitor patients. Now, taking a patient from CAR T cell to allogeneic stem cell transplant is not a minor decision. It's a major decision. One cell therapy given, you're planning to do another cell therapy, one which is much more involved, has got more toxicity and morbidity risk. We have to be careful about which patients we choose. But if we are using Brexucel, we are very diligent about the MRD monitoring and looking for disease evidence to make that decision on our patients. Next slide, please. Now, I didn't speak much on the obe-cel, but the obe-cel is a CD19, is a 41BB. And as I mentioned, that the attractive bit of this product was the safety was very high because the CAR T cell does not attach to the leukemia cell for a longer time. We also used the split dosing strategy, which is dosing dependent on the disease burden that was there in the bone marrow. And they tried to do a study looking at a consolidative allogenic stem cell transplant. Again, the study was not designed to answer the question, but what gave me a bit of confidence with this data was they tried to answer the question both by censoring the patients who went for allogenic transplant and not censoring. And they could not find a lot of difference happening. Just telling that perhaps with this product, allogenic stem cell transplant may not be required for all patients. There will certainly still be some patients where the question needs to be asked, but certainly not. The requirement does not look as imminent as we could see in the Brexucel or the Tecartus data that we were seeing. Next slide, please. Now, they also ran at the month 3, they looked for CAR T persistence, and that gave them an additional variable to look at. And they saw that if the CAR T cells were persistent, again, numbers are small, that the CAR T cells were persistent at 3 months, those patients continue to do quite well as compared to those who had lost the persistence of CAR T cells. So this was seen in the Tisacel or the Kymriah group. Obe-cel has brought it, and again, as I have said that with the 41BB co-stimulator, it is possible to do this. So it is an important variable to consider in making ongoing decisions for our patients. Next slide, please. Now, I discussed about allogenic transplant, what's actually happening in the registries. And I just put this slide to just give a sense of what's going on. And this is the data from the CIBMTR, and the CIBMTR publishes data on patients who are getting allogenic transplant in ALL. And in this particular graph, they have split it into 2 groups. One, patients who got prior CAR T cells before an allogenic stem cell transplant, and patients who never got a CAR T cell. Now, patients who got a prior CAR T cell, we don't know why they moved to an allogenic transplant. Was it already a decision that was made? Whether the patients actually lost the benefit from the CAR T cells, whether they became MRD positive, we don't know the reason. But just giving you an idea that Brexucel was approved in 2020, and since then there has been a steady more than 50% group of patients who are getting allogenic stem cell transplant in the US that have actually received CAR T cells prior to an allogenic stem cell transplant. It would be good to understand the decisions. I think one of the drawbacks in registry data is that they cannot give you that granularity of information, but some data to watch for where this trend eventually goes. Next slide, please. Now, there are real-world consortiums in US, and they've done some excellent work. And the ROCA consortium is one of these consortiums that has collated work on patients who got infusion with Brexucel. Now, remember, the Brexucel or the ZUMA-3 study was only 55 patients. So certainly we want larger numbers to look at this, and this was the larger numbers. 189 patients infused with Brexucel. 79% of these persons had a very good response, MRD negative CR. And 16% was still MRD positive, and some group of patients, the MRD status was not known. Next slide, please. Now, one of the things that they did was they wanted to answer the question of allogenic stem cell transplant, and they looked at these cohort of patients that they had, and they split them into 3 groups: who never had a transplant, who had a transplant had after the CAR T cells, and who had relapsed after a transplant and then went on to have CAR T cells. And they looked at the survival of these patients as to what was going on. Now, all these patients who are included in analysis had achieved MRD negative CR after the CAR T infusion. Next slide, please. So when they looked at the group that had achieved a CR that was MRD negative on flow cytometry, and this is just with Brexucil, they found that the group that never had a exposure to transplant did the worse. The group that had a post CAR T cell allogenic transplant, the curve was at 1 year was 76% was the outcome. The group that had a prior allogenic transplant had still a superior survival as compared to the group that never was exposed to an allogenic transplant. And their survival at 1 year was 58%. Now, this is more hypothesis generating. We don't know why we are seeing this, whether allogenic stem cell transplant provides more immune graft versus leukemia effect, whether when you are generating CAR T cells in a patient who's already had allogenic transplant, those CAR T cells, when they are genetically manipulated and converted to CARs, have a greater alloimmune effect. These are some of the possibilities that are possible, but it seemed that the question of transplant is pretty much embedded when we are using Brexucil in our patients. For the group that never had an allogenic transplant, interestingly, they found that patients who were older, who did not have a high-risk phenotype, had a non-PH-like phenotype, and who were MRD negative pre-apheresis. Now, that's a very deep response. Even pre-apheresis were the group that had a lower risk of relapse and had a good survival. Next slide, please. Now, having told you what's moved globally, it's heartening to see that the field in India is also moving. And I put up this slide from the TaliCell, which is I understand is the ImmunoAct CD19 for 1BB co-stimulated with the humanized CAR product, which has got impressive overall response rate at day 30 of around 88% and at day 90 of 75%. The median progression-free survival is 18 months, and the median overall survival not reached. And the median period of follow-up when this was published this year into 2026 was 12 months. Now, this is again impressive because they managed to do the same paradigm that was originally established in the ELENA study. There were centers all over India that collected cells, leukapheresis cells, managed their patients, send it to ImmunoAct. They generated the CAR T product and send it back. So establishing that supply chain paradigm that was established. Now, of course, as we moving forward and we are getting more and more CAR T cells come in, allogenic CAR T cells are out to challenge this whole supply chain paradigm. But what's going to really challenge the supply chain paradigm is the in vivo CAR T cells, the ones that we've seen impressive results in myeloma, the Kelonia CAR T cells. We haven't heard about any work in leukemia. There is work being done in lymphoma. And the in vivo CAR T cells will challenge this supply chain paradigm that we have established with autologous CAR T cells. On the right, I have also mentioned the Immunonil Therapeutics, which have got their CD19 CAR T cells. My understanding is they are approved in India only for the lymphomas yet, though I think in Spain they are approved for the leukemias as well. And of course, Vellore, where I did my training, have published their point-of-care CAR T cells, which is another interesting concept that's coming in. Rather than having centralized production or manufacturing of CAR T cells that requires GMP facilities, what about doing point-of-care CAR T cells, which is again an interesting concept. Next slide, please. Now, the relapse of CAR T cells still remains a problem, and the relapse can be CD19 positive, can be which is that might be because the T cells that we have generated, the CAR T cells are not persisting, the CAR T cells are not persisting, or the CAR T cells were generated from T cells that had an exhausted phenotype. And a lot of things that could be responsible for that. The prior treatments the patient may have had, the age of the patient, and sometimes the post-CAR factors like the co-stimulatory molecule may have a role. We are only beginning to understand that microenvironment may have a role in this. PD-L1 and L1 may have a role, and this was There are some efforts to use PD-1 inhibitors in patients who relapse after CAR T cells to see whether we can get some response and response in the leukemias. Next slide, please. Next slide, please. Of course, the bigger concern is the CD19 negative relapses that we see, and this could be from many reasons. We believe that in most of these patients, there is a small pre-existing clone that has got selected from the selection pressure. There could be alternative switching. In P53 leukemias and in KMT2A's leukemias, there is a switch. There is a risk that there could be a lineage switch that has happened. And sometimes in low antigen, we get a phenomena called trogocytosis, where the CAR T cells themselves nibbles off the membranes from the leukemia cell and incorporate CD19 on their own surface, and that causes a bit of fratricide or fighting between the CAR T cells and kills the CAR T cell. So the table on the right tells you the incidence of CD19 relapses, which depending on the kind of product, depending on the kind of stimulator, there is a variable risk of a CD19 relapse happening in patients. It really is important to screen your patients and see that there are no CD19 negative leukemic class populations present prior to committing to a CAR T cell on the patient, because that's the best way to prevent a CD19 relapse happening on our patients. Next slide, please. Now, the future directions in CAR T cells, because relapse is still an issue, how do we move forward? Or use different targets, use CD22, work from NCI has done the CD22 CAR T cells, or we use a combinatorial strategy, put CD19 CAR T cells, CD22 CAR T cells, or we use bispecific CAR T cells, CD19 and CD22 CAR T cells in the same CAR T cells. We use third generation, two co-stimulatory molecules, armored CAR T cells, where we cause IL-12 or IL-15 release and cause expansion or more expansion of the CAR T cells. Use allogenic CAR T cells, third-party T cells to generate CAR T cells, less exhausted, but the risk of immune rejection remains high. Or we combine with PD-1 inhibitors. So there are a lot of strategies that are being tried. Of course, some of the strategies that are being tried are whether we can use maintenance strategies for patients who are getting CAR T cells. A paradigm that's getting well established in patients who get CAR T cells for Ph positive ALL, where we can have the option of using tyrosine kinase inhibitors for these patients to consolidate that response. There's a small cohort of patients or pediatric patients from the University College London where they've tried to use maintenance chemotherapy in some of these patients, but these are evolving strategies that we are still studying and are trying to find the best strategy for our patients. Next slide, please. What sort of algorithm are we looking in the future? We are looking at relapse, and this is in the present era. We are looking at patients who have relapsed B-cell ALL. Of course, if they are CD19 negative, we can't use a CD19 CAR T cell. We will hope to get CD22 CAR T cells or some different bispecifics CAR T cells for the patient. But for the patients who are CD19 positive, we do have an option of using a CD19 CAR T product. We would like a good T cell for a patient. We would apheresis and generate the CAR T cells. Of course, in the future, we expect that if our patients have got an exhausted T cell profile or multiply treated, allogenic CAR T cells may become available, but these are still experimental at that time. And then once we give our CAR T cells to a patient, the question is whether we need to do an allogenic transplant. And this is something that we are trying to finish, trying to understand better which are the patients. It's a combination of the product that you're using, the disease that they have, and the patient's response that will tell us which patients would need consideration for an allogenic stem cell transplant. Of course, if the patient relapses after a CAR T cell, in the future, we hope we'll have other products, we'll have other strategies, and of course, concurrently exploring, as I mentioned, TKIs for Ph positive ALL. Now, the field of CAR T cell, I have spoken about only relapse refractory CAR T ALL today. But the field of CAR T cell now is moving into a consolidative strategy. And in ASH last year, there were two trials that were presented, one for Ph negative ALL from the City of Hope, where they used in elderly patients who had MRD negative responses from chemotherapy, CAR T cells as a consolidation strategy. Short follow-up, but very effective. They demonstrated very elegantly that the CAR T cells still expanded. They demonstrated elegantly that the CAR T cells actually went into the CSF. So that was very good data. And this is likely where the field will move, because the benchmark for giving CAR T cells is definitely a bit lower than doing an allogenic transplant. And it's going to be probably the direction in which we will start pushing for our elderly ALL patients. There was similarly a Chinese trial where they did CAR T cells similarly as consolidation strategy for Ph positive ALLs, and again could show excellent responses. So that's where the field is moving in terms of how CAR T cells will be placed perhaps in the future. Next slide, please. Now, we spoke at length about BALL, and the TALL is really an orphan child because TALL, we don't have a lot of treatments for relapsed TALL. But that is changing because we have now a fair few groups doing allogenic CAR T cells against CD7 for TALL that are proving to be quite effective. We are involved in this trial, which is a trial from a company called Wugen, which has got anti-CD7 allogenic CAR T cell. The T cells are genetically modified. They because it's allogenic product, they knock off the TCR that prevents GVHT, prevents rejection. They knock off the CD7 from the T cell, and as a result of this, there is no fratricide, that is no CAR T cell fighting happening. And they put in a CAR against anti-CD7, very effective, used with the enhanced lymphodepletion. Response rates are in the order of more than 90%, with composite CR rates of 72%. But sadly, because it's an allogenic product, because it causes cytopenia, it's still being used as a bridge to move to allogenic stem cell transplant. Similar work done from groups in China where they've used an anti-CD7 CAR T cell product from the Ormond Street Children's Hospital. Again, they've used an anti-CD7 CAR T cell product. Each are slightly different in terms where they are how they're genetically modified. But it seems that the field for a T cell ALL is showing a bit of promise with anti-CD7 CAR T cells now moving in that direction. Next slide, please. So that was my last slide, and I would like to acknowledge all the patients and families that we work with. The CAR T cell is never a single person job, it's a whole team. We've got a team of our nurse coordinators and fellows and our apheresis team, my hematology colleagues, our excellent nurses, laboratory services, and also CAR T cells, we need a lot of input from and support from neurology, our intensive care, our emergency department. So it's a big team effort. And so I'm acknowledging them. And I'm again apologizing for all the technical issues that we had today. Next slide. Thank you for your attention and happy to take questions.
Thank you, Ashish. It's, I think, change of date for you already.
Yes, it's change of date for me. Yeah.
Great job. Beautiful. I haven't heard a better lecture on CAR T than what you delivered today. So beautiful. So much of learning. So we'll take up some questions. We straight away have one in the chat box from Dr. Krishna Ratnam. For MRD negative patients, how do you decide between allo BMT and CAR T? How do CAR T expand in MRD negative patients?
Okay. The second part of the question is very easy. When we are talking of MRD negativity is subject to the sensitivity of your test. Even when we have MRD negativity of 10⁻⁻⁴, we know we've got X million leukemic cells still somewhere in the body, and they are good enough to cause the CAR T cell to expand. And the work that was done out of City of Hope was very elegant in showing that. They elegantly showed that even in patients who are MRD negative CR, they were seeing expansion of CAR T cell. The first question is actually subject to what's registered and what's accessible. We can access CAR T cells only for patients who got relapsed disease. So if somebody is an MRD negative CR, I don't think the question of CAR T cells yet is being very well established. What I mentioned was being done out of City of Hope is a clinical trial. We'll have to, they did it as a single institution trial. I understand after speaking to them that they are actually going into a multi-center trial using obe-cel to try to study that further. And that data will be interesting because if they can show that they can achieve a good fraction of cure or survival in those patients, then that will become the standard of care. And of course, if that becomes the standard of care and if obe-cel is the product available, the bar that you have to cross for allogenic transplant is higher than what is crossed for CAR T cells. And so I think the field will then move towards CAR T cells for the patient you are asking me the question for MRD negative high risk patient that you still want to consider a consolidative strategy. Perhaps we'll move to CAR T cell. At this point, we are not ready. We have to consider allogenic transplant, unfortunately, still for those patients.
Thank you. Anybody else has any question? Okay, if no, then in that case, Ashish, thank you very much.
Sure.
Great talk, enjoyed. Thank you.
Sure. Thank you. Thanks for your time. Thank you. And sorry about all the IT issues. Thank you.
Small thing. Prashant, go ahead with the vote of thanks.
Yeah. Thank you very much, sir. And it was a nice presentation by both. And indeed, it was a very informative and well-defined presentation. I am really thankful for Dr. M.B. Agrawal, sir, for his continuous endeavor for this kind of webinars. And at last, I just want to say that on the behalf of Adler Oncology, I just want to say thanks to all of you participants, discussants, and the eminent speakers. And lastly, Dr. M.B. Agrawal, sir. And we will be continuously, we will stand beside you, sir, for each and every endeavor of yours. So I just hand over to you now. Thank you.
Thank you.
And goodbye.
Ashish, and thanks to everybody else.
Thank you.